on director at SIEPR in Stanford, and also the Wayne and Jodi Cooperman Professor of Economics. Some very influential papers over the years. You worked with the Obamacare administration on the Affordable Care Act, but today I think you're talking about a social insurance scheme in California, and looking forward to your findings and learning from your insights. Thank you, Mark.
Great, thanks so much.
And is it okay if we record your talk?
Sure, yeah, that should be fine.
All right, thank you.
Just, I'm gonna try to share my screen here in a second. And let's see. And then I may talk a little bit big picture before I get into the paper. So let's see. Actually, can I do that before I even share the slides, or you can? I can just tell you a little bit about. So
yeah.
Most of my research has been on the U.S. healthcare sector, although I have written one paper that does not study the U.S. system, and that was actually on India's system. Chirantan, I think you know about that paper looking at the effects of patent reforms introduced in India about 15 years ago on the price and availability of pharmaceutical treatments in India. And that was a really enjoyable paper. And one thing that I really learned while I was studying for that paper was that the US and healthcare system differs a lot from the India healthcare system. So I guess I want to apologize in advance for the we're going to be talking about a healthcare system that's very different from the system that you all have there. But I think at a high level, before I get into sharing the slides and the presentation, a big issue in the US healthcare system, and I think in India's healthcare system, is what role should the government play in the system? Should the government own the hospitals and hire the doctors, or should the government contract that out to hospitals or to private health insurers to coordinate and finance that care? And that's like a constantly evolving thing in the US. Like, what is, so, and right now, as some of you may have heard, we have a presidential election coming up, and the two candidates have very different visions for what role the government will play in the healthcare system. The US healthcare system stands out from any system in the world in the sense that we spend more as a fraction of our national income on the healthcare system than any other country. So we spend about 18% of our GDP on healthcare, whereas the second highest country, I believe, is Switzerland, which spends about 12% of its GDP on healthcare. And there are a complicated set of reasons for why we spend so much more than everyone else. And if you look, US relative to other countries, we actually don't get, you might think, well, we're spending all this money, then it must be the case that the US is getting massively better health outcomes. Well, that's actually not true. If you compare the US to other industrialized countries, our life expectancy or infant mortality rates are actually not very good relative to other industrialized countries. So, I think one of the big questions in health economics in the US, and I think this is true really in any country, health economics, is what is the payoff to spending more in the healthcare system in terms of improving health, let's say, or improving people's financial protection, or improving the quality of treatments in the future. So, at a high level, I think the question, the study that I'm going to describe today is very specific to the US. It's a reform that was introduced in California for a health insurance program that I'll describe a little bit. But at its core, it's very similar to the issue that India faces, that Germany faces, that Brazil faces, that Australia faces. of like how do we want the government to be involved in this healthcare system. And so with that, I will start to present, and feel free to send questions my way or not, whatever works best for you. I'm going to try to share my screen, and Chirantan, maybe you can just let me know if I am successful in doing this, because sometimes I screw up. Let's see. Okay, I'm going to try to share this and then put it into.
Yeah, it's coming. You can see it.
Can you see now?
Yes.
Is it? Let me just see. Is it in presentation mode?
Yeah, now it's on show slides mode.
Okay, perfect. Yeah, so once again, thank you so much for having me here today. It's really an honor to be here, and I wish that I could be there in person. I've actually never been to India, but I would love to go someday. So I hope, and Chirantan, it was great to connect with you when you were at Stanford a year or two ago. And yeah, so I'm really appreciative to be invited, and wish I could be there to see all of you in person. But the research that I'll be presenting today is a paper that is co-authored with two former students. One, his name is Craig Garthwaite. He's a professor at the Northwestern Kellogg School of Management, which is a business school at Northwestern University here in the US. And also Adelina Wang, who just completed her PhD studies here at Stanford in June, and is doing right now a postdoctoral fellowship at the National Bureau of Economic Research. So it's been great collaborating with both of them. And to the extent that you think that anything in here is good or interesting, it's probably because of them. any mistakes or limitations are probably because of me. So let's see. So let me, before I go through this slide, let me just say a few things about health insurance in the US. So about 91% of people in the US have health insurance. And that health insurance is basically, like any kind of insurance, exists to transfer money from good states of the world to bad states of the world if bad things happen. So people have life insurance, people have insurance.
Mark, you have an audio issue. You're coming in and going out a little bit. So
I am. Okay, let me try to, is it any better now?
Yeah, we can hear you, but there's a little bit of coming in and going out, but yeah, please continue.
Okay, I apologize for that. I will try to not move around as I'm presenting here. So in the United States, about 91% of people, 9 in 10 or 10 in 11 people, have health insurance in case they have a significant health event and they have to go to a hospital or get some expensive care. That health insurance can help cover the costs of that care. And there are 4 different ways that people can get health, 4 main ways that people get health insurance in the US. One is through the private sector. So most people have private health insurance. And of that group, most of them get it through their employer or through a spouse's or a parent's employer. And then the 2 big programs are Medicare, which is health insurance for the elderly and the disabled. And then there's a program called Medicaid, which is the one that I'll be studying today, which is a program for people with low income and assets in the United States. And those are 2 of the biggest government programs in the US. They cost an enormous amount of money. So Medicare it has about 65 million people on the program, and the cost per year is over $750 billion. So it's over $12,000 per person per year. Medicaid has about 75 million people, and the cost of that program is about 700 billion. So it's a cost of about $9,000 per person per year. So it's an enormous amount of money that we in the US spend on health insurance through these 2 big programs, Medicare and Medicaid. And the 4th biggest group is the set of people who are uninsured, people who do not have any health insurance. And there are some other small groups, but those are the kind of the big ones. So privately insured are about 160 million. Medicare is about 65 million. Medicaid is about 75 million, and the uninsured is about 30 million. So that's just to give you a sense. I mean, we have obviously fewer people. You have 4 times more people in India than we have in the US. So we have about 330 million people in the US. So that's just trying to give big picture on the health insurance system in the US. Medicaid is the program that I'm going to be talking about today. And it provides health insurance for people with low income and assets. Chirantan, am I a little bit better now? Does my sound a little better?
You're perfect. Keep going.
Okay, great. So it is what's called a means tested program. So it's a program that you can only receive if you have low income and assets. And it costs a lot of money, about $600 billion. And in the United States, this program is administered by state governments instead of the central federal government. So in the US, we have 50 states, and each of the states administers their own program. And there's a fair amount of difference between the states in terms of the details of their programs. And this was expanded by, so 10 years ago, I worked for President Obama's Council of Economic Advisors, and we created this legislation that expanded this Medicaid program. Most of the states, they didn't have to expand it. Most of them decided to expand, including the state of California. And it is a very diverse program. So just to give you a sense, each day in the US, there are about 11,000 babies born, and half of them, their health insurance costs are covered by Medicaid. So, and then on the other age of the end of the age distribution are nursing home residents. So in the United States, we have about 1.4 million people residing in nursing homes, and 2/3 of them are insured by Medicaid. And then there's many, many people between being babies and being in a nursing home who Medicaid covers. And it's a big program, and it's a complicated program. And so what I'll be talking about today is something called Medicaid managed care. What Medicaid managed care is the state basically decides we're going to contract out this health insurance to a private health insurer. And so that's like, it's outsourcing.
The audio is still out, Mark.
Oh, can you hear me now? I'm sorry.
It goes out. Now good. Yeah, now good. You have to probably come.
So I think I just have to be really close to
that. Yeah.
Okay. Sorry. I'm sorry about that. So I'll just stay close. So sorry if everyone sees a zoomed in on my face. Sorry about that. And yeah, interrupt me, please, Chirantan, at any time if it's not sounding good, and I'll try to make it better.
Sure.
Medicaid, so state Medicaid programs increasingly are doing this contracting out. And why do they do it? One reason is it simplifies things for them, because if they contract with a private insurer, they can just pay that private insurer a certain amount per month, and that's it. They don't have to worry about negotiating prices with hospitals, with doctors, with pharmacies, and so forth. They just have one set of negotiations with an insurer, and they can coordinate and finance everything. So I think that it simplifies things. And it also, you could argue, could make things more efficient. Maybe the private firm does a better job of coordinating care relative to what would otherwise be a fee-for-service system. So in a fee-for-service system, if you're on Medicaid and you show up to the hospital or the doctor and you get some care, the government directly pays that hospital or physician for your care. But they may not, so the government doesn't do usually much to try to coordinate that care. So for example, if I went to one doctor and that doctor ordered a set of tests, and then a week later went to a different doctor, if you were in a private insurer, the private insurer may be more likely to let the second doctor know, hey, this person got these tests next week, so you don't need to run them again. And so it's possible that it leads to better coordination of care. And there's been a huge increase in the use of this Medicaid managed care over time. And so I've written previously about this, but recently, one of policymakers though are worried about doing this for a number of reasons. Probably the biggest is they're worried that private health insurers will, to use the economist phrase, shirk on quality. They will not provide high quality. They'll cut corners and provide lower quality care, especially for the sickest and most unprofitable patients. And so there's a fear with this kind of contracting that the most vulnerable patients will suffer because the insurer will give them low quality care, partly because the insurer hopes that they won't remain in the plan. Because, I mean, the way this system works, some patients the insurer makes money on because they don't get much care. Other people, the insurer loses money on because they get a lot of care. And, you know, I think there's a fear, and this dates back, you can see lots of research on privatization, like Oliver Hart, Nobel Prize winning professor at Harvard, has done work with Andre Schleifer, also at Harvard, and Rob Vishney in the Quarterly Journal of Economics, that sort of fleshes out some of the challenges associated with privatization. So this is, and there's a lot of a variation in the use of this Medicaid managed care across states. So this map just shows the 50 states in the US. I'm in California, which is over to the left, the big state over to the left. It uses Medicaid managed care quite a lot, but there are other states like Texas and Pennsylvania and Washington state that use Medicaid managed care much more. And then there are some other states who barely use it at all. And so you can see this, you know, from the map. So there's variation, and that's something that's true, very true of government policy in the U.S. That there are there's a lot of variation across states in the U.S. with respect to how they use managed care. Okay, let's see. And so there has been an increase in the use of Medicaid managed care. So the figure on the left shows how many people in the US are enrolled in Medicaid. The bar chart shows how many are enrolled in Medicaid, and the blue part of the bar shows how many are enrolled in Medicaid managed care. So you can see about 80 million people enrolled in Medicaid, and about 60 million of them, or 63 million of them, in Medicaid managed care. And as a share of spending, it's also been growing. And until recently, Medicaid managed care was restricted to the healthiest patients. So because the government was worried that for the sickest patients, the disabled and the elderly, that the insurers would shirk on care and give lower quality care. So it's only recently that governments have started moving into contracting out care for the most vulnerable patients. Does this making sense somewhat so far, Chirantan?
Yep.
Okay.
And I'm requesting everyone to plug in their questions.
Yeah.
We will take it back to Mark at an appropriate time.
Yeah, feel free to let me know if you want me to stop for a little bit and pause and ask questions, because I'm going through a lot of information. And I know if someone was presenting this sort of information about India's healthcare system, for example, I would surely be confused.
That's quite a debate right now, how much to privatize universal healthcare in India. So.
Oh, is that right? Okay.
Yep.
Okay. Well, I don't know. Hopefully then this is a little more relevant. So here I've alluded a little bit earlier to the benefits and costs of contracting out. So on the plus side, maybe it can lower spending, maybe it can improve quality for those reasons that I mentioned there. On the other hand, maybe it will end up being more expensive, and maybe the quality will end up being lower. And so there's trade-offs, just like everything with economics, there's trade-offs. On the one hand, it's good, on the other hand, it's bad. And ultimately, it's an empirical question whether the pluses outweigh the minuses of this sort of policy. And so in this study, we're going to try to estimate the effect of Medicaid managed care on the utilization of healthcare and on health outcomes. And we're going to focus on people with disabilities for whom there's been very little research about this. So there's been other research by other people, including me, on Medicaid managed care for healthy patients, for for kids who just need their like annual checkups and that kind of thing, not people who have really serious health conditions. Okay, and so we're going to use the fact that this program, so many things in the healthcare system are voluntary. So prior to the reform that I am studying, a person with disability could opt into Medicaid managed care if they wanted to, voluntarily. And so it's very hard in that kind of a setting to estimate the causal effect, because you worry that the very factors that cause the person to enroll in Medicaid managed care may also influence your outcome variable of interest. So it's an endogeneity problem, and it exists. Like, there's been tons of papers written with these kinds of endogeneity problems. So, for example, people looking at, let's say, the effect of training programs on earnings, and they look at people's earnings before and after, but people signed up for the training program for endogenous reasons, and so you have to deal with that. But here in this study, we're going to leverage the fact that there was a mandate for people to enroll. So they no longer had an option. So in 2011 and 2012, in 12 big counties of California, they moved from basically fee-for-service for their patients with disabilities to privatized Medicaid managed care. And then some people were exempt from the mandate and so forth, but we're going to look at the effect of this. And what we're going to do is, it turns out that instead of having everyone join Medicaid managed care at the same time, they phased it in somewhat gradually, so that people who were born, I believe May or June was the first month. If you were born in May or June, you were required to enroll in May or June of 2011. If you were born in July, then you were required to enroll in July of 2011. Now, you might be 50 or 60 years old, but they staggered this, and I'll show you a picture in a second. But we're going to use that variation in the timing of people moving into Medicaid managed care to try to estimate the effect of this at a simple level, to compare outcomes for people who were required to enroll first with the outcomes for people who weren't required to enroll until later. And so it's kind of a, to use the phrase that economists use a lot, it's kind of a differences in differences analysis. And you can see this in this figure. So I apologize if this is kind of messy, but what this figure shows, so on the horizontal axis is the month and year. On the vertical axis is what share of hospital admissions are in Medicaid managed care, in these private Medicaid managed care plans. And then there are 12 different series that are shown for people who are born in May, for people who are born in June, July, and so forth. And as you can see, the people who were born in May were switched into Medicaid managed care about a year before the people who were born in April. And so, and here I'm plotting this only for people born between 1950 and 1969. So this is approximately, this is people who are in their 40s and 50s. Okay, so this is not kids, this is not the elderly, it is kind of a middle-aged group of people. Okay, so, and then there's a whole literature that has, that is somewhat related to this paper, and I cite a bunch of the papers here. There's contracting out of government services, and I mentioned that Oliver Hart paper earlier by the Nobel Prize winner about this. There's been, so that's just contracting out government services generally. And one of the things that literature stresses is that it's very hard to write a complete contract for all situations. So certain government services are pretty easy to privatize. Like in the US, a lot of governments privatize garbage collection. So they hire a private company to come and pick up people's garbage once a week. And that's like a simple government service. It's easy to monitor. And you know, the stakes are not very high. If they do low quality, maybe there's a little bit of trash on the ground outside, but it's not life or death. It's not like get a kid getting their schooling. So those kinds of services, this literature has stressed, are usually contracted out. Whereas the more complicated stuff, like education, healthcare, police protection, are less frequently contracted out. So that's just government services generally. Then there's a literature on Medicaid managed care, what I referred to. There's a research on managed care and private health insurance. And there's a literature on what effects health insurance has on health. So those are sort of 4 different literatures that we're connected with. And I apologize if you've written a paper in one of these areas generally, and that we haven't cited it because we can't, but in any case, this is some of the literature.
Mark,
so I'm just Chirantan, I don't know if you or anyone else has any questions, but I'll stop there for a second.
Yeah, so my faculty colleague, Professor Tarun Jain, has a question, and I do have another question. So Tarun asks, what are the frictions involved for an individual to enroll, or is it an automatic enrollment?
It's pretty automatic. That's a great question. So with the mandate, it became pretty automatic. So essentially, like a mailing or email was sent out to recipients. Not all recipients have email accounts. So for those who didn't, it was sent by regular mail, and basically informing them that they were going to be required to enroll in this plan and that they could pick between the available plans. And if the person did not make the choice, then they would be defaulted into plans with a random probability, so that they, you know, didn't overwhelm any one plan with people. But so they tried to eliminate the frictions. And I think, you know, that those frictions, now that's, I think that's a great question. Those frictions partially explain why a very small share of people were enrolled in Medicaid managed care initially, because it would require filling out forms, going to an office. It's just a hassle. And I think, you know, a lot of people didn't do it or even know about the options. So yeah, great question. And Chirantan, you said you had a question too?
Yeah, so I think California has 58 counties, right? And
Yeah,
they staggered
58.
it out in 12. So I'm just thinking what was happening in the remaining 46 during this period.
Yeah, so I'll talk a little bit about that. That's a great question. Several of the counties already had Medicaid managed care mandates in effect. So they were already treated. And then I'm just going to go back a slide. You'll see the lists of the counties here. You see that Los Angeles is one of the counties, San Diego, San Francisco. A lot of the big urban counties are among these 12. So I'd say there were about 7 or 8 big urban counties that had already moved to Medicaid managed care before 2011. And then there are like, I don't know, 25, 30, 35 counties that are more rural, where they are still, they're not in Medicaid, they haven't moved to Medicaid managed care. So these reforms were introduced primarily in the urban areas where there are a lot of people. And so in the rural areas, they didn't do it as much. So we're gonna have in our analysis sort of 2 different types of control groups. One control group is gonna be people within these counties leveraging the fact that some enroll, as you can see here, earlier than later, right? So one set of analyses, we're basically just comparing, you could say, people in Los Angeles who were born in May with people in Los Angeles who were born in April to see, did health outcomes improve or did health spending decline for the people born in May relative to the people born in April because they were enrolled a year earlier. So that's one set of analyses we're going to do. In a different set of analyses, we're going to compare these counties, these 12 counties that had this staggered implementation, with 8 or so counties that already had Medicaid managed care in effect. So essentially, and so that's sort of 2 different sets of analyses, and the results are pretty similar regardless of which of those 2 approaches we use. But yeah, that's a great question. Okay, so should I keep going?
Yeah, please.
Okay, great, thanks. And I, once again, I apologize for all this institutional detail. One thing that is unfortunate about studying healthcare, there's so much institutional detail. I'm sometimes envious of my friends who study the tax code or income inequality or something else very quickly, because it's pretty, like, you know, income inequality, you don't need 20 slides to explain all the institutions. So let's see. Okay, so Medicaid managed care in California. This sort of gets to Chirantan, your question, which is what was happening in the other counties. And so this talks a little bit. And there was some Medicaid managed care in the other counties already. You know, the rural counties, they later implemented Medicaid managed care. This is sort of where they are today. But at the time, they did not have much Medicaid. So you can see, this is a figure I showed earlier. There's an increase. And, you know, basically one thing that I like to do in my research, honestly, is have some kind of figure like this early in the paper where there's been a big change. And so here you can see very clearly from these figures that the role of Medicaid managed care in California has grown a lot. So I would say the vast majority of my papers have some figure 1, like one of these, which shows, you know, here's a change. And theoretically, it could be good, it could be bad. Let's try to see if it's good or bad. And that is that, I mean, that a lot of what I do is, and you know, you could say that's kind of simple, but I don't know. I usually am very drawn to studying economic policies, and policies are often changing in interesting ways. And I don't know. I don't know how much in India the policymakers pay attention to evidence about policies in thinking about whether to change them, and if so, how. But you know, I hope they do. So here's the data that we have. 3 main data sets, and it's like with all things, the data is not perfect. We don't have everything we'd want, so we try to make the most out of the data that we have. So the first data set that we have is every hospital admission in the state of California. So California is a big state. It has 40 million people. Now, I guess maybe in India that's not big. That's only 3% of that would be only 3% of India's population. But it's a big state, 40 million people in California. It's bigger than Canada, has a higher population than Canada. And so it's every hospital admission in the state of California over a more than 10-year period. So that's one data set that we have with really detailed information about patients. The second data set that we have is every visit to the emergency room. So when patients, if let's say I went out for a run and I don't know, twisted my ankle and thought it was broken, I might go to the emergency room. And there are lots of things. If someone gets hit by a car or shot, they're going to be taken to an emergency room. So we see all of them, and there are about 2.5 times more emergency room visits than there are hospital admissions. So you can see about 10 million a year versus about 4 million a year. We also have death records. So everyone in our data, if they die between 2009 and 2013, we know that, even if they die outside of the hospital, which is really important because most people do die outside of the hospital. And so there are a multitude of limitations with this data. One limitation, for example, is we don't observe care that's done outside of the hospital. So if a patient's getting better access to prescription drugs, if they're getting better access to physicians, we can't see that. We can only see it to the extent that it affects their utilization of the hospital. And additionally, if someone never goes to the hospital, we never see them in this data. So that's, you know, a limitation that I think is important to keep in mind. Okay, So now we're going to construct the analysis sample for our analysis, and we're going to focus on the 5-year period from 2009 to 2013. You could ask, why do we stop in 2013? Why not look at long run effects, which we would love to do? But in 2014, Obamacare, what's called the Affordable Care Act, was implemented in California.
Mark, sorry to interrupt you, but I think you need to come closer to the laptop or machine.
Yeah, okay. Can you hear me a little better now?
Yeah.
Okay, great. Sorry again. So let's see. So we focus on this analysis sample over a 5-year period. And so how are we gonna construct our analysis sample? We're going to restrict attention to people who had a hospital visit in 2009 or 2010 and who were born between 1950 and 1969. So one way that we're trying to differentiate ourselves from the prior literature is that most of the prior literature has looked at kids or the elderly. So we're trying to look at non-elderly adults, people like in their 40s and their 50s, because this was the group that was most affected by the mandate. Chirantan, is it a little better now?
Perfect. Please
okay,
go
great.
ahead.
Yeah, and we're going to merge the discharge data and the ER data, and then collapse our observations to the person quarter level. So you can imagine, like, one of our outcome variables is going to be, did you get hospitalized in the quarter? And for each person, we'll have about 20 quarters of data. We'll be looking from 2009 to 2013, so 4 quarters a year, 5 years. And that is mainly what we'll be looking at. And so here's all sorts of data on the sample. Let me just call your attention to a few numbers in here. So first, in terms of the average age of our sample, it's about 50. And the majority of our sample is female. So about 63, 64% are female. They are actually more likely to be on Medicaid. And the share who are underrepresented minorities, Black or Hispanic, is also higher than in the population average. And then you can see the different kinds of insurance that people have. So MMC is Medicaid Managed Care. MCD fee-for-service is Medicaid fee-for-service. And so you'll see that we have three other kinds of insurance that exist: private health insurance, self-pay, which means you're uninsured, or other. And this is because in the US healthcare system, people's health insurance changes a lot from one period to the next. So, we restricted attention. Remember, we started our sample with people who were on Medicaid in 2009 or 2010 and visited the hospital. But at some point in the subsequent, at some point during that period, they may not have been on Medicaid. They may have been privately insured. They may have been uninsured. So, most of our admissions are on Medicaid, either managed care or fee-for-service. But they are moving to some other kinds of insurance. And another issue in our data is that in the hospital admission data, we can see if a person is Medicaid fee-for-service or Medicaid managed care, whereas in the emergency room data, we only see if they are Medicaid. So that is like another limitation of our data. And you can see, here's just some information about the sample in the pre-period. We've got about 132,000 people who are in our analysis sample. We select the sample based on that first year. Then pre-implementation, this is before things start to get, the mandates start to get rolled in. There's some data on those same people. Then there's the implementation period, and there's the post-implementation period. So you can think of there being 4 distinct time periods. The first year when we're selecting our sample, the year before the implementation, the year of the implementation, and the year after the implementation. So we're looking at sort of 4 distinct periods. Okay. And then this is in the control counties. Now there aren't as many people in the control counties. You can see about 19,000 people versus 132,000 in the treatment counties. That's probably because the treatment counties have a lot of the big counties in California, like Los Angeles and San Diego are the 2 biggest counties in California. In terms of people, they're in the treatment group. So our control group is smaller for sure than our treatment group, which is, all else equal, we would prefer to have them be about the same size. Okay, and you can see here some information about Medicaid managed care status. And so here we've bucketed people into 3 groups. The first group is people who were always in Medicaid managed care. The second group is people who were initially in fee-for-service and switched into Medicaid managed care, presumably because of the mandate. And the final sample consists of people who always stayed in Medicaid fee-for-service. And as I alluded to at the outset, there were sometimes exceptions so that a person could get out of the mandate. So maybe if a person had needed a certain kind of care and the insurer didn't provide that care, they could get an exemption from the mandate. Okay. So then here's some information about the characteristics of the group and their charges. And you can see that these patients are pretty expensive. So on average, the average charges for one of these patients is about $50 or even up to $75,000. So you can see the people who are in Medicaid fee-for-service always, they're more expensive. And so that's consistent with the idea that the most vulnerable patients, they didn't move. And so that is, that's some information on our background sample. So before I describe empirical strategy, let me just pause for a sec to see if you have any questions. Okay, I'll keep going. All right, so our empirical strategy is we're going to exploit the staggered implementation of the mandate. And we're going to have 2 sets of analyses, one in which we only use the reform counties, and one in which we use both reform and control counties. And there's an identifying assumption whenever you have an empirical strategy, and we're assuming that the timing of the mandate is unrelated with other factors that might influence health outcomes, okay? And so I think that seems pretty reasonable for the born in May versus born in April difference. It's unlikely those 2 groups are different. They're like 50 some odd years old, like that, and they're born a month apart. So we think that's a pretty good assumption, but it's an assumption, so it's worth flagging. And we're going to look at heterogeneity in baseline patient characteristics. So we're going to look to see if things work better or worse for sicker versus healthier patients. Okay, so the main specification is pretty simple. You can see here outcome Y in county for person I in quarter T, so unit of observation is the year quarter, and we've got this mandate variable. And beta 1, we are arguing, is the causal effect of the mandate on an outcome variable of interest. We'll start with health insurance to see if it affects health insurance much. We've got time fixed effects, person fixed effects, and so beta 1 is we think, given the assumptions outlined above, capturing the causal effect of the mandate on the outcome variable of interest. Okay. And we're going to explore the timing to see if there are any pre-existing trends, because you might be worried if in the months leading up to switching, something was changing. So once again, we're going to control for time fixed effects and individual fixed effects. So we can follow, that's one thing I didn't mention earlier, is that there is what's called a record linkage number in the data that allows us to follow the same patient over time. So that I think is we're pretty happy to have that. And so here you can see the change. This is the share of all hospital discharges in California. The top series is in Medicaid fee-for-service, and the bottom series is in Medicaid managed care. And as you can see, there was a really big change as this thing was getting implemented. So it was both were pretty flat before May 2011, and both changed dramatically and in basically opposite directions beginning in that month, in May 2011. And if you look at it and the magnitude of the change, it varies by age. It was a bigger change for older patients. So you can see at the bottom, for people born 1950 to 55, they were much less likely to be in managed care than the people born in the 1970s or early 1980s. So it was a bigger change for the older patients, and we think more vulnerable patients. And then we're gonna, and this gets to a little bit to Chirantan, your question. You can see in our data what share of the this with counties that already had Medicaid managed care in effect. And so what you see is that before May 2011, Medicaid managed care was much higher in those other counties, which we call COHS counties. But then in the reform counties, they caught up and actually passed it. And that's as a share of all discharges, because remember, Medicaid isn't everything. There are a lot of people who are privately insured or on Medicaid, Medicare, or some other program. But if you look at this as a share of Medicaid recipients over to the right, you see bigger numbers there. So the Medicaid managed care share really increased steadily during the implementation period in the treatment counties. So hopefully this makes some sense. And so this is now just some regressions. And I'll just call your attention to a couple of the things over to the left. So over to the left, inpatient Medicaid managed care goes up. Inpatient Medicaid fee-for-service goes down, okay? And then you can see that, so there is definitely some change happening in insurance coverage here. Now, so that is, you can see, but in terms of what effect, so that's, this is looking at the first stage. Does it affect people's insurance coverage or not? And it looks like it does. So you can see here from this figure that when we use the reform counties only, or when we also introduce the control counties, you see there's a sharp increase in the probability of being enrolled in Medicaid managed care, about a 25 percentage point increase in the probability of being enrolled in Medicaid managed care after this mandate goes into effect. Okay, now let's look at whether it affects if people use the hospital at all. So this now, this variable will turn on regardless of whether the person is in fee-for-service Medicaid or managed care Medicaid or some other insurance. What you see is an increase in the likelihood that people go to the emergency room and an increase in the likelihood that they are transferred to another hospital. So one of the things that I haven't talked much about, but that is true for these managed care plans, is they selectively contract with hospitals. So like in the County of Los Angeles, there are more than 100 hospitals. A managed care plan will usually contract with a small number of those hospitals so that they can get better rates on their services. So that they, it gives them more leverage in negotiating the contract rates. But what that means, and whereas Medicaid fee-for-service tended to have contracts with most of the hospitals in an area. So what that means is often, if you're in Medicaid managed care and you show up to an emergency room, but you're not in that hospital's network, your plan is not in that hospital's network, that hospital may say, you know what, we can't treat you, we're going to transfer you to another hospital. And so that you see that both an increase in emergency room visits and an increase in transfers following this move to Medicaid managed care. So one of the arguments for Medicaid managed care is that it would lead to fewer emergency room visits because maybe people would get better preventive care and so forth, but that does not appear to be happening. And so here you can see just an event study version of this, that it looks like there's an immediate increase in the probability of going to the emergency room, although the magnitude of this effect declines over time. And it is a little frustrating, I will admit, to not have more precision, given that we have so many observations in our data, but it's just, we're trying to adjust the standard errors to account for potential issues with, so it's statistically significant early on, but then later the confidence interval gets bigger. And then we do some analyses to look at the emergency room visit by type of visit, and you can see there's like different, so we see different kinds of effects depending on the kind of visit. But because of time limitations, I'm just going to forge ahead a little bit. You can see here's some information on people getting transferred, more likely to be transferred. And then I want to show this research on what type of hospital you go to. So I don't know if this is true in India, but in the US, there are three primary types of hospitals. There are hospitals that are owned and operated by the government. There are hospitals that are owned and operated by private nonprofit firms. And there are hospitals that are owned and operated by private for-profit firms. And what you see is that there is actually, at least for hospital admissions, a decrease in the use of teaching hospitals and of government hospitals, and an increase in the use of for-profit hospitals. Maybe because those for-profit hospitals are, they charge lower prices. I'm not sure, but that, we see this variation in which types of hospitals people are going to. And healthcare in the U.S. is big. It's a lot of, like, there's financial incentives matter in the healthcare system, and so it does appear that where people are getting their care now changes. Finally, we do some analyses to look at what effect does it have on mortality, if any. And if anything, we find a modest increase in mortality coming from this move into Medicaid managed care. And that effect seems to be bigger for people who at baseline were sicker. And so we see evidence of a slight uptick in mortality. And here you can see the event study version of this. And then we do a bunch of robustness checks to leave out certain counties. And we find that our results are not driven by any one county. And then we also look at different baseline conditions. And we find that people who have heart conditions are the ones whose mortality goes up the most as a result of the of moving into Medicaid managed care, whereas other patients are not much affected. And then we do a bunch of robustness for this. And so what we see is that patients with more severe conditions and complex needs appear to be more affected by insurer incentives. And it matters a lot. Like it does seem, so you could have asked, why did policymakers not move these disabled patients into managed care plans earlier? It's precisely the reason that we are finding that the sicker patients seem to do worse in this Medicaid managed care regime, in this privatized regime, than in the previous regime. And we don't know the exact mechanism for that, but it looks pretty robust. And then we do a bunch of, just because of time limitation, I apologize, because this is a slide deck I have used for an 1.5-hour presentation, and we have only an hour, so I'm going through fast. I wouldn't have, anyway. So this is looking at emergency room visits also seem to go up for people with high baseline utilization, not for the people with low baseline utilization. And we do some stuff with another measure of baseline health, which is this Alex Hauser score and Charles score and so forth.
Mark, you need to come close to the computer.
Yeah, come close to the computer, yeah. And then let me just see. And then we find some heterogeneity by type of plan. So it turns out I've sort of grouped all of the counties into reform counties or non-reform counties. It turns out that in some of the counties with the mandate, there were several different private health insurance plans. So Sacramento and San Diego, whereas in others, there were only 2 plans. And we do some analyses to see if the effects are different for those 2 types of counties. And we don't find huge evidence of difference on this. So I know that I am approaching being out of time. So let me just conclude by saying we had a really, so this is, US healthcare system. It's very different from India's healthcare system, but hopefully the big picture, this idea of what role do we want the government to play, is something that you find of interest. So we see there was a very large shift of Medicaid recipients, fee-for-service Medicaid to Medicaid managed care. And we find substantial heterogeneity in the effects of that Medicaid managed care. The sickest patients appear to suffer adverse consequences, including an increase in mortality, though, and so it does seem to support policymakers being anxious about privatizing for the sickest patients. And this also suggests there's been a lot of research in the US that has looked at the effect of health insurance. 0-1, do you have health insurance or not? And this suggests that whether you have health insurance can matter, but also what type of health insurance you have can also matter. So anyway, hopefully that is, I tried to not give too much institutional background, but enough so that it would make sense. But I don't know, Chirantan, if you have another question or two.
There's an empirical question, but I think, okay, so someone has asked, Ashish has asked, was a patient born in April or later months had the option to enroll early? So I
Yeah,
think
they
from
did.
the,
Yeah,
yeah.
that's a great question. I think they did have the option to enroll early, which could complicate things, but it looks like relatively few exercise that option. And it may be which may itself be telling. They would have had the option to enroll in the program even before May of 2011. So they should have always had that option. I think in practice, it may have been hard for them to enroll early in that year because the government and the plans were so busy enrolling the people who had to enroll. But that's a great question and something that we haven't thought much about or looked much into. So I appreciate that.
So Mark, I had this question. I didn't want to stop you in the beginning, but um, this selection of the patients with disability, did you had some ex ante intuition that something wrong is going with their access to care and outcomes as a function of the policy changes, or you just randomly chose it because the data came to you like that?
So I think I've always been interested in this question of contracting out for the sickest patients. And I think the analogous, you can think of this for any government service. Like, let's suppose we contract out schooling for the most difficult kids. Let's suppose we contracted out jail for the most dangerous criminals. You know what I mean? Like, how does that work? And one of my advisors in grad school did a lot of research on incomplete contracting. It's very hard to write a complete contract when the service is very complicated. It's easy to write a complete contract for garbage collection pickup. You know what I mean? It's easy to write a complete contract for the healthy patients because you can just say right in the contract, you have to give them a flu shot each year. You have to give them an annual checkup each year and specify a few more things in the contract. For the patients who are really, really sick and, and who are maybe, especially people with, let's say, who are, their health is really bad, they themselves may find it difficult to monitor the quality of care that they are getting. So I think theoretically, it seems plausible that the most vulnerable patients, the effects for them could be different for the sort of simpler patients, just because of I think it's great to have the profit incentive to encourage efficiency. Big believer in the private sector of allocating resources efficiently, but it's definitely true that if you're a health insurer, you have a financial incentive to treat your most profitable patient best, right? And your least profitable patient, just theoretically, like and so it's not clear that happens, but health insurance is a very skewed, healthcare costs are a very skewed variable. The majority of patients are profitable, but there's a small minority who are hugely unprofitable. And so I think just thinking about like how that affects the kind of care people get, I think that was what we were drawn to.
Awesome. I don't see any other questions, and we know you have a class in a few 25 odd minutes. So thank you so much, Mark.
Yes.
We really appreciate your insights, and I really like the way you started out giving the big picture, because these are debates that are happening in every country, and I think we can position these findings in the context of the policy learnings even in India. So much appreciated. And
thank you so much for having me. I'm sorry. I know the time is great for you guys. It's 12-hour difference is like very hard, right? It's not, so the timing isn't great for either you or me, but it's not terrible for either of us. So it sort of works. Yeah.
Yeah, and we have a committed group of participants today. So they're small, but they're interested in your work. So thank you so much again.
Thank you so much. And Chirantan, I hope we'll get a chance to interact before too long, and that things there for you are going well too.
Yeah, and we would love to have you on campus. Stay safe, Mark. Take care. Bye-bye.
Okay, thank you so much again. Okay, bye-bye.